Welcome everyone. We'll just wait a couple of minutes while people join in. Okay, we might start now. So good morning everyone and welcome to the Australian Centre for Value-Based Healthcare webinar, How Hospital and Healthcare Facilities Can Reduce Clinical Risks and Improve Patient Outcomes with Timely Test Result Review. I'm Emma Hoban. I'm the Policy Manager at the Australian Healthcare and Hospital Association, and it's my pleasure to be your host today. Before we get underway, I would first like to acknowledge and pay respects to the traditional owners on the many lands on which we meet today, and recognise their continuing connection to land, water and culture. I'm currently on the land of the Ngunnawal people in Canberra and pay my respects to their elders, present and emerging. We are all set for a very interesting discussion today, and I'm sure it will inspire some questions. So we have a dedicated Q&A session at the end of the webinar, but feel free to put your questions as they occur to you throughout the presentation in the Q&A function at the bottom of your screen. So to the webinar topic. In healthcare, the inadequate follow-up of test results is a key patient safety concern with possible severe consequences for care outcomes. Patients discharged from the emergency department are at particular risk of having test results pending at discharge due to their short length of stay, with many hospitals acknowledging that they do not have reliable systems in place to managing such results. In today's webinar, we will be joined by Associate Professor Dr. Richard Paoloni to explore how timely test results review can improve the safety and effectiveness of clinical diagnostic process and optimise patient health outcomes. Associate Professor Richard Paoloni is an experienced senior emergency physician, fellow of the Australasian College for Emergency Medicine, and an associate professor with the University of Sydney. He is the Chief Medical Advisor for My Emergency Doctor, coordinating the activities of the fellows of the Australasian College of Emergency Medicine employed by the company. Associate Professor Paoloni's previous roles include the New South Wales Faculty Chair of the Australasian College of Emergency Medicine for a period of 4 years, and as Director of Emergency Medicine at Concord Hospital for 12 years. Richard was the former Chief of the Australasian College of Emergency Medicine Standards and Workforce Subcommittee, and he has a strong interest in streamlining access to emergency care, developing and refining new models of care, and promoting high-quality services within emergency medicine consultation. So I'll hand over to you now, Richard, for the presentation.
Great, thanks, Emma, and thank you everybody for joining us this morning. I was thrilled to hear that there was a good number of participants. This is something I've had a strong interest in for a long time. I think we focus a lot on the quality of care we provide to patients when they're in front of us, but it's equally important to ensure they get proper follow-up, that there's good communication ongoing, and today we'll talk about why that's important in terms of the results of tests that come back after the patient's discharge from the emergency department. Undoubtedly, there's also importance and value to this in the inpatient hospital setting, but that's not my area. And so I will be talking predominantly about emergency department patients today. So what we're going to talk about is why it is important. I've done a number of studies in this, and we'll talk about, in brief, 3 of those, and how you can leverage the findings and understand, have an understanding of what your facility's approach currently is to handling test results, and make an assessment of whether that needs some refinement or whether it's doing the job that it's supposed to be doing. And then, as Emma said, we'll have a Q&A session at the end. I hope to leave plenty of time for that, so that we can have a good discussion about the various issues in achieving this. Next slide, please, Judith. Okay, so the clinical context. So why are we ordering tests? Well, we're ordering tests. We should be making a clinical assessment of the patient and coming up with a provisional and a differential diagnosis. Our provisional diagnosis should be the diagnosis that has the highest pre-test probability based on our history examination and bedside tests. We're then using investigations such as laboratory and radiology tests to adjust the probabilities, to confirm that something is more likely or confirm that something is less likely, so that we can refine that differential diagnosis and come up with a working diagnosis and a treatment plan. So we should not be ordering tests unless it's going to make a difference to our diagnosis and management plan. And so therefore, every test we order should be important from a patient care perspective. So we have a responsibility to not order inappropriate tests, not to order low value tests. And that's a whole other talk. But we also have a responsibility that if we have ordered a test, and therefore we do consider that that test has an implication for patient care, we have a responsibility to check the result of that test and to follow up with the patient if required. Next slide, please, Judith. So the importance of results. Most tests that we do in the emergency department, and obviously the emergency department gets some priority in terms of laboratory turnaround times. So most of the tests we do in the emergency department are resulted and are checked prior to patient discharge. So most of your common blood tests, such as your electrolytes and your full blood count and those things are done and back in time, and they don't need any further assessment. Imaging results do come back in real time. We do get various sorts of provisional reports. So ED clinical staff will normally be making assessment of plain X-ray images. And then in terms of more complex imaging like CT or ultrasound, or in rare circumstances, MRI, we may be getting a radiology registrar provisional report. It's not that common in most health settings to actually get the formal report before the patient is discharged. It does happen in certain places, but it's not common. What is more common is that formal radiology reports are often quite delayed. And indeed, in some places I'm aware of, even in New South Wales, plain X-rays either take weeks to get reported or are never formally reported. That, again, is a separate issue. But for the ones that are reported after the patient's discharge, we need to have a process for looking at those results and adjusting care where appropriate. Almost every microbiology test, particularly because a number of them actually require germs to grow, almost all of those take days, sometimes longer, particularly if you're talking about TB tests or various types of complex serologies that need to be sent to places like the Westmead lab. They may take even weeks to come back. And again, we have to have a process so that those sort of tests, which obviously we thought were important, do get followed up and do get fed back to the patient and to their ongoing care providers as required. Next slide, please. So, it's a potentially a very big problem. And, at the end of the day, the problem is impacting patient care as the primary issue. And as we said, it can be days to weeks that the results come back. We need a clinician to check the results. It's not just a matter of reading through a results. You need to be able to understand the importance of what's being reported, and you need to be able to, if necessary, integrate that with the clinical information to decide on the course of action. So a certain report may be very meaningful in one patient and not so meaningful in another, depending on the clinical situation that they presented with. And if necessary, the clinician needs to act upon it as quickly as practical. And those actions can be many and varied. In the majority of cases where it's something that needs to be addressed, but it's not of an urgent nature, that's probably a communication with the patient to let them know about the result, and a communication with their GP or another ongoing care provider, such as a specialist who they see regularly and to whom it's relevant. So you need a clinical brain to interpret the result in the clinical context, and then you need a clinician to then interpret how that changes the management plan and how to enact that change to the management plan with both the patient and their care providers. Any delays in that process, any unnecessary delays, because obviously there are delays invoked in, say, microbiology. There are, delays involved in actually obtaining the result, just because that's how long it takes. But any other delays or failure to check the results can lead to patient morbidity and, in some cases, patient mortality. Some simple examples. A common thing that we find is urine cultures indicating a urinary tract infection. The patient has been given antibiotics. So it's been diagnosed as a urinary tract infection. They've been given antibiotics, but the culture sensitivities suggest that they have resistance to the antibiotic they've been given. It's a pretty common circumstance. We're prescribing antibiotics at the time without the knowledge of what germ it is and what its sensitivity pattern is. And that though, even if it says it's resistant, it may give a response, it may not, and may cause ongoing symptoms and discomfort and time off work and etc. That's a pretty common sort of circumstance. One of the well-reported, although rare, instances where delays or failure causes mortality is in patients with lung cancer. So the situation is that they presented to the emergency department, they've had some shortness of breath, or they've had some chest pain or some other chest symptom. Lung cancer was not really the obvious diagnosis, wasn't really the provisional diagnosis. We were looking more for pneumonia or pneumothorax or something like that. So we've done the chest X-ray, we've interpreted the chest X-ray. Clearly, we're most interested in the diagnosis that we're looking to either prove or disprove. And we failed to notice a subtle soft tissue lesion in a different part of the X-ray. That's then reported when it's formally reviewed. Obviously, the radiologists, one, have more experience in these things, and two, they're a little bit more removed from the clinical circumstance, and so are doing a much more thorough total investigation of the image. They identify that there is a lesion there that needs further investigation. Lung cancer can progress very, very quickly, and what could have been a early diagnosis and a curative operation then becomes a disseminated cancer, not amenable to treatment or not amenable to cure. And in some cases that will lead to early mortality. Rare, but very well reported. That instance certainly has been reported in a number of cases, and it's a nature of that disease that progresses very quickly through a potential curative stage to a not curable stage. And it's really important to have an audit trail. If we don't have an audit trail, we don't know how we're performing. We don't know how quickly we're looking at these results. We don't know who's looking at these results, and we don't know, whether we're actually doing what we would like to be doing, which is looking at 100% of these results within a very reasonable time frame and acting on them on behalf of the patients. Obviously, some of these, like the delay to diagnosis of lung cancer, may end up in a court scenario, and again, there have been court cases around that. And so an audit trail is also important for medico-legal purposes, but I do want to stress that that's not the reason to do this. The reason to do this is patient care. Next slide, please, Judith. So I'm just going to run through a couple of studies that show different aspects of the topic. Actually, could we go, there's a slide for the 2009 study. I think the slides have possibly got out of order. Or maybe we skipped one. Are you able to go back and just see? Because I think there was one from 2009. Nope. Okay. All right. I will refer to my other screen over here. So, oh no. Okay. All right. Anyway, so we did do a snapshot study in 2009 at the hospital where I work. At that stage, we were fairly early adopters of electronic orders and electronic results review. So those were already well and truly in place. So that both our microbiology tests and our radiology tests, which are the predominant ones we see in emergency that come back after we discharge the patient, both of those were electronically ordered and electronically resulted. At that time, a lot of places were still on paper. So even in our place where we were ordering and able to look at the results electronically, the formal result was printed and a pile of paper was brought down for you to sign off. So at that stage, so we're talking 2009, what's it, 13 years ago, we looked at 1 week of all radiology and microbiology orders from our emergency department, and we tracked them all the way through to see how many did not get acknowledged. In our circumstance, it was actually quite low. It was around 3%, so it was not nothing. But compared to the literature at that stage, but on paper-based systems, which were reporting anywhere between 20 and 40% of results never being acknowledged. So it certainly did suggest that having electronic ordering in place, obviously that allows you to track the orders a lot better than orders that are on pieces of paper. So certainly that seemed to have an impact at that stage. Then skip a few years and we come to 2017. And this study, also done at the hospital I work at, looked at pre and post implementation of a electronic results acknowledgement. So within our, essentially it was like a results inbox, and any result where the ordering clinician was in the emergency department and the patient's discharge date and time was before the result date and time, would be sent to this inbox. And that inbox was shared between all of the specialists in our emergency department, so any one of them could sign off on those results. They could also, because the result was in the inbox, in the EMR, not an email program, they could also quickly jump to the clinical record and review the clinical context for the patient. So they could also document directly into the EMR at the time that they were reviewing the results. So it was a fully encapsulated electronic process from result ordering all the way through to result acknowledgement and documentation of the actions that arose from that. So we did a pre and post implementation study. There were semi-structured interviews with all of the different specialists, emergency physicians who would be responsible for the joint sign-off of results, as well as direct observation of them signing off the results, and a time and motion study of that. And that was done pre and post. Interestingly, there wasn't any change in the time it took to review the results. Some were faster, some were slower within particular subtypes of results, but the global time to review a certain number of results remained unchanged. But the work practice did change substantially. And I think the key one here is that because the results acknowledgement process was within the electronic medical record, it made it very easy to look at the clinical information. It was timely, it was easy to do, etc., as opposed to having a piece of paper with the hospital record number and then having to search on the EMR for that patient to get to the record, which is obviously a slightly clunkier and more time-consuming process. So what we saw was that after we implemented a system where it was easier to get clinical information, there was a substantial increase in the number of clinicians who went looking for that information. And I think what that says is that because it was easy, the threshold to do it was lowered. And, in that 8% difference were probably the ones where, it's a little bit ambivalent whether you do or don't, etc. But I think it encouraged people to look for the information because it was easy to look for the information, and therefore to actually provide a higher level of scrutiny of those additional results. Next slide, please. So in this study, we also were looking at pre and post implementation. This was another hospital within our local health district, and it was again the implementation of the same electronic results acknowledgement, but at a different hospital. In this study, we only looked at radiology reports, and we looked at 1 month pre and post implementation of the results acknowledgement. The month before, we brought in the electronic results acknowledgement. So this site, similar to us in 2009, was doing electronic orders and able to see the results electronically, but was still receiving the final result on paper. And despite an exhaustive look through everywhere that those pieces of paper could end up, we could only show that about 70% of those results had been acknowledged. And that was as little as a set of initials scrawled on the piece of paper, or as much as an entry into the medical record. So any form of acknowledgement was counted as acknowledgement. Post the implementation, when all the results were electronically delivered to a centralized inbox within the EMR, etc., 100% of results were acknowledged. We then looked at abnormal results. So we pulled out the normals and then re-looked at that. It was about the same. So, whether the result was normal or abnormal didn't affect whether it was acknowledged in the pre section. And then what we did was, for the abnormal results that had not been acknowledged, we wanted to know what's the clinical significance of those results. And so we gave those results to 2 emergency physicians who were, independent of that site, but do clinical results review. And we asked them to rate the significance of the result, like the clinical significance of the result, as low, medium, or high. And we also asked them, what did they think that if nobody did anything about that result, what was the likelihood that it would cause morbidity to the patient? And again, it was a sort of mild, moderate, severe type rating. There were only 3 cases where the 2 didn't agree, and we had a third person, a third emergency physician, resolve those ones. So the result was that a third of the abnormal results, which were never acknowledged, were felt to be clinically significant, and half of those were felt to carry a moderate likelihood of patient morbidity if they had not been acted upon, which they had not. From a patient safety point of view, this information was fed back to the site so that they had the opportunity to follow up on these results. Next slide, please. All right, so that was some of our findings. And then the question is, well, what can you do about it? And I think what we can learn from it is that it's really important to understand how you're doing now. And that's the whole process. So for all of these results that come back after a patient's discharged, how long is it taking to get the formal report? How long is it taking to get the formal report to the clinician who is responsible for acknowledging that result and ensuring there's no follow-up required? How long is it from when it gets to that person how long does it take for them to look at the result and action it if appropriate? What proportion of all of these results are actually being acknowledged? And as I said, the timeliness factor. So unless you know your current performance, you don't know whether you've got a problem, and you don't know where in the system the problem lies, and therefore you don't know how to address it. So I think knowing your current performance is step one. If you don't already have an electronic results acknowledgement system, I think there is very clear evidence from our study and from a number of other studies that in terms of closing the loop and making sure that all of the results that do eventually get a formal report arrive to the emergency physicians, I think it's invaluable. It essentially takes it to 100%. If you can embed that within your EMR such that it's easy to go from the result to the clinical notes of the patient, and it's easy to document in the electronic medical record so that other care providers can see what happened, that is the optimal situation. Understanding that it's an essential clinical quality and patient safety activity. So to me, this is not an optional extra. We ordered the test. We ordered the test because there was a reason to order the test and we felt it could impact patient management. We therefore have a responsibility to chase the result of that test and ensure that if it does indicate that there should be a change in patient management, that information is conveyed both to the patient and to their ongoing care provider, and often with a recommendation of what we feel should be done. I think that's just essential, and I think that we have to do it, and I think it is every bit as important as the patient care we provide when the patient is in front of us. Next slide, please. The electronic result review endorsement or acknowledgement eliminates unacknowledged results. 1 in 6 of those unacknowledged abnormal results will carry moderate patient morbidity. If your results acknowledgement is within your EMR, your clinicians are more likely to look at the clinical information when interpreting the results and better contextualize the result and provide a more appropriate management plan for that patient. Changing from paper to electronic doesn't have any meaningful impact on time. So if you're doing it because you think it's going to save your clinicians time, it's not going to save them time. But what it is going to do is it's going to mean that they get the clinical information more often and they provide a better service, and that they look at all the results, not just 70% of them. And it is an essential component of a quality emergency service and should be included in your quality framework and should be periodically audited to ensure you're actually meeting the benchmarks that you would like to be achieving. And I think that's it. All right, back to you, Emma.
Thank you very much for that, Richard. So we'll now open the Q&A. So if you have any questions, please put them in the Q&A function at the bottom of your screen. But we'll start with the question that I have for you, Richard. What are your thoughts on the test result review timelines in Australia, and where are we compared to other countries?
Yeah, look, it's an excellent question. I think it's very, very variable. Particularly, microbiology is probably not that variable. Most of the delays in microbiology are not so much around waiting for somebody to report on it. It's more about the time it takes to do tests and having to wait for germs to grow on plates or in bottles, culture bottles, etc. Radiology, I think, is very, very variable. Particularly plain x-rays. As I said, I'm aware of some places that, at least until recently, a number of plain x-rays would never, ever be reported. In other places, there are delays of weeks to get a formal report, whereas in places that have appropriate resources and are well organised, it may only be the next business day or two. CTs are generally reported in a more timely fashion. As I said, most of the time they're not reported before the patient's discharged home. For those places that are using off-site reporting, often 24/7, they would be the exception. So they might get a finalised consultant report before the patient leaves, but that's a fairly small proportion of sites in Australia. So most of the time, there will be a delay, but I think it's making sure that that delay is not an unacceptable delay.
Thank you, Richard. So a question here from Joe is, can you see of any possibilities that the time factor for acknowledgement could be made faster with some enhanced electronic results management system or other work practice change?
Yeah, I mean, I think that certainly, having it set up such that the laboratory program or the radiology program, essentially, as soon as that result is endorsed as final, delivers that result to the clinician. Technologically, that's not hard. So I think that that is a given for setting up this sort of thing, that there shouldn't be any sort of delay in an electronic result being delivered to the clinician. The delay is really then from, a result that arrives at 3 in the morning is not going to be looked at 3 in the morning. So it's a question of aligning your resources so that you have sufficient resource that result is looked at probably on the next business day in most circumstances. I don't know that anywhere currently is looking at them on weekends or public holidays, just from a resourcing point of view. But just ensuring that you have somebody who's dedicated to that task on every business day, and that they have sufficient time available to look at those results and action them, so that they're not being unduly delayed in that part. I think that's where the delay happens most of the time.
Thank you, Richard. What do you think are the key challenges preventing more timely test result review in Australia, and how do you think we can address them?
Yeah, I think it is that clinical resource that is the biggest challenge. I think all of us are struggling with clinical resource for service delivery, with emergency presentations going up at sort of 4%, 5% and 6% per year. And I can assure you our staffing's not going up to that rate. So I think everybody is challenged by their resourcing in terms of both direct patient care and service delivery, but also in terms of the clinical support activities, including results review. So I think that there's no easy answer to that. We can't just magically create a whole lot of jobs and a whole lot of money to pay for those jobs. But it's about acknowledging that this is an essential part of a quality emergency service, and therefore it does need an appropriate amount of resourcing to be put towards it.
Great. So kind of building on that, do we know what proportion of hospitals have an electronic acknowledgement system within their EMR, or like an estimate of that? And do we know if there are certain communities that are missing out on the benefits from such a system?
I'm not sure I know a proportion that have them. They're certainly a lot more common today than they were even, I mean, we only implemented it in 2017, and that's with myself and others who were clinically very proactive to get it implemented. So yeah, I mean, even we've only had it 5 years. So I suspect there's a lot of places that don't have it, but I couldn't give you a number. I think there are definitely places where this system, even in a more rudimentary form, doesn't exist. And, certainly I think that the resourcing challenges in regional and remote areas are going to be much greater. Now, the volume of tests is possibly going to be less, but the pressure of resourcing is going to be huge.
Just a reminder, if you do have any questions, please put them in the Q&A at the bottom of your screen, and Richard would love to answer them for you. So another question from me, Richard. What are your thoughts on the role of technology in enhancing diagnostic process and review timelines?
Yeah, I think there's a lot of places that technology can help us. The human parts of the test acknowledgement process are obviously important, but technology can reduce the gaps between those human processes. So, for example, a CT scan, when I was a lad, took a very long time. If you took a trauma patient to the CT scanner, for a head, neck, chest, abdomen, or so-called pan scan in those days, you got somebody to go and buy your lunch because you were going to be there for 40 to 45 minutes. These days, it's done in 2 to 3 minutes. There is still a bit of a lag in terms of the processing time of CT images, particularly reconstructions. So that does depend on computing power, but the actual acquisitions of the scans is now very, very fast. So yeah, there is an opportunity to increase the efficiency of the post-image processing, and then technology to deliver that to the person who's responsible for reporting that scan, which does exist. And as I mentioned, there are private companies that are employed to provide 24/7 reporting, sometimes offshore, and all of those images are digitally transmitted in real time to those people. So technologically, it's all possible. It just has to be set up. And in a lot of cases, the images are stored locally and wait for a person to come in and review those locally. So again, there's a potential for enhancement there. The digital delivery of the result is generally not hard to achieve. And because the results are going to come in asynchronously, there is possibility that there could be alerting functions or other things to notify you that a certain number of results are there, or results have been waiting a certain amount of time, etc. Because obviously, if you don't go looking, you won't know. And I happen to know what time our radiologists tend to sit down and do their reports, because that's when they come. They come in this 1 hour at the end of the morning and this 1 hour at the end of the afternoon. So you tend to jump on at the end of that session, but for a lot of places, it's not that predictable. I think there's also a growing role for artificial intelligence in this space. And there are already programs being trialled in clinical practice in Australia, particularly around chest x-rays, which, as I said, the lung cancer example is one of the drivers of that. And the AI program works alongside the clinicians in the sense that the image is delivered to the clinician and they get the opportunity to look at it, and then they can press a button and the AI will assess the image and say, hey, have you thought about this? Because this image seems to have X on it, etc. So it's a prompting function. It's not a over-reading function. And that can be used both in the real-time reading in the emergency department by the emergency department clinician, but it can also be used by the radiologist. And the accuracy of those programs is growing substantially, and for things like pneumonia and things like lung cancers and things like pneumothoraces is excellent. And so I think those things are going to increasingly come into our practice probably over the next 5 years.
Very interesting. You mentioned before, and as we all know, there's growing and increasing pressure on the health workforce. A recent study has reported that hospital doctors in Australia perceive EMR systems to be difficult to use, of poor quality and with limited or no benefits. Many of these problems have been blamed on systems being developed with a focus on data collection and billing, rather than supporting clinicians to improve workflow for better patient care. Your study on work practices showed no change in the time, as you highlighted in a number of times, but the work practice changed substantially when the electronic results acknowledge system was implemented. What do you think are the key changes to work practices that people should be cognizant of when implementing such such a system, and how can they be effectively managed to ensure the system is implemented?
Yeah, well, there's a lot of stuff in there. I agree with the comment that a lot of systems have developed for data collection rather than clinical process. And part of that arises from the fact that where you start with a clinical system is you start with patient demographics. And so the system is all built around fields and data and etc. But that's not the way that clinical information is best presented. I think there's also an issue in that, in this country, we didn't have enough clinician engagement in the design of electronic medical record systems. And it's only fairly recently, like probably the last 10 years, that places have had positions like a chief medical information officer or a chief nursing information officer, somebody who's actually given some paid time to ensure that clinical utility and usability and design and etc. is incorporated into the EMR process. The people who design computer systems are very good at what they do, but they're not clinicians. And clinicians and IT people speak very different language. I enjoy trying to integrate IT into clinical processes, and I sometimes describe myself as a translator because I take clinician speak and I'll call it geek speak, and translate it for the other party. The worst thing you can do is put a whole lot of clinicians and a whole lot of IT people in a room together because it's a dog's breakfast. But there is a translation problem there, and so I'm certainly not being critical of the IT people because I think they sometimes get very poor direction from the clinicians, and trying to get 3 clinicians to agree is hard. Trying to get 50 clinicians to agree is impossible. And the IT people need agreement on what are we building. They can't build, this nebulous system. So I think there are challenges. I think having clinical people with paid time to get involved and ensure that the clinical needs are represented when these systems are being built and when these systems are being integrated is vital and is happening, but slowly. I would warrant there's still a large number of places that don't have those sort of positions. And then there's a feedback element to it that clinicians are very pragmatic. They're also very smart. They will find a workaround when something doesn't work the way they want it to, but they're also not that good at actually feeding back that there's something they would like and getting it into the build program, etc. They will live with it and whinge about it far more often than they'll actually report it back. So I think clinicians need to get involved in these discussions and they need to be willing to provide feedback. If you don't ask, you don't get.
Yeah, no, very interesting. Do you think there's a way that clinicians can, I suppose, upskill themselves in tech speak?
Well, I don't think they should need to be honest. I think that's where that chief medical information officer or that chief nursing information officer role comes, that the clinicians should be feeding back to that person with concrete examples of where the system is not meeting their needs and why the system's not meeting their needs and how the system might better meet their needs. And then that person getting the collated information of the medical group or the nursing group can then feed that back to the IT people and make change. I think trying to teach all the IT people clinical language and the clinicians' IT language would be a mess.
Yeah, no, that makes sense. So back also on the topic of workforce wellbeing, as we know, our workforce has been 2 years of responding to pandemic, and there's more and more burnout being demonstrated, including ongoing furloughing of staff, resulting in future pressures on the workforce for providing that safe and quality care. Do you see digital support in line with what we've discussed today as having a role in relieving pressure on the workforce And are there any words of caution in how we implement such solutions in an overstressed workforce environment?
Yeah, no, it's very interesting, and I think there is a real issue, and whether people are burnt out, and undoubtedly some people are. There are a lot of people who aren't burnt out, but they are just exhausted, mentally, physically, emotionally exhausted. And so, yeah, I think we need to be conscious of that, and we need to acknowledge that we're not going to be able to implement things as quickly as we would like in that sort of circumstance, and that therefore we need to take a bit more time, we need to engage more, and that change is always stressful for people, some more than others. And so we should be looking at doing less change, but doing it better and with better clinician engagement. I think that's what we need to do to minimize the distress, the emotional distress, but also the cognitive load of change. So I think we need to be focused about, well, what are the most important things we should be doing, and then to really make an effort to engage with all the key stakeholders, take their concerns into play, and work with them as to when's the right time to bring it in. But excuse me, I think that we need to stage these things and just acknowledge that people don't have the mental bandwidth to cope with rapid change at this point in time. They've been doing that for 2 years, and they're exhausted.
Yes, it's an iterative implementation approach that.
Yeah, and focusing on the things that do actually provide efficiency or productivity gains for the clinicians. Recognizing that the imbalance between demand and resource just seems to be growing. How can we shrink that or slow that growing gap by using clever IT and good implementation and good UX or user experience design and there's lots of data out there, both in the electronic health record space, but also, Google know how to do it, Apple know how to do it, and they've published lots of stuff of how to make the user experience better. So it's not that we have to start from ground zero, but we need to bring it in earlier and engage the clinicians earlier, I think.
And we all know that with technology and new technology adoption, there can be some hesitancy and fear around new technologies. Obviously, the pandemic has gone a long way to help us kind of overcome that, because we've had to adapt so quickly. How do you think we can help people to overcome their hesitancy around the adoption of new technology?
I think you're right. We have, as a needs must, adopted a lot of change very, very quickly. But also that change has been fairly haphazard because we haven't had the time to properly plan, integrate it into current systems, etc. It's just had to happen. And it therefore has introduced a lot of cognitive load, a lot of anxiety, a lot of uncertainty and confusion, because there's been a lot of mixed messaging and there's whole lots of the system that are not integrated well at the moment. So I think the first thing we need to do is to actually, now that we're in a more plateau period, we need to step back and actually just relook at everything we've done over the last 2 years and decide which bits we need to keep, which bits we don't need to keep. And for the bits we do need to keep, look at it as if with new eyes to see, okay, if we're going to keep doing this, how do we make it work in the overall context of, say, an emergency department? And who's responsible for it, and what are the actions, what are the outcomes? Look at it like a project, but look at it like a project from scratch, because it just got chucked on top of everything else and not properly done.
Okay. So we've got another question here from the audience. How do you feel about patients accessing their own test results?
Yeah, look, really good question. And there is actually a paper that we looked at this. We looked at emergency physician perceptions of patients getting direct notification of results. I have mixed feelings about it. I think that it can be quite alarming if you get results that are not normal, and you don't have the clinical context to, work out whether it's something bad or not that bad, or, etc. So I think that, reporting back normal results, I don't really have any great problem with. I think that's fantastic. I think it's reassuring to people. I think that getting, in our circumstance where people come to emergency and they always think they're going to die. Thankfully, very few of them do. But a big part of it is anxiety and fear, and getting reassurance to people as quickly as possible where it's clinically appropriate is fantastic, because you can see that suddenly they feel a lot better, because they're worried, and the longer they go with nobody talking to them, the more worried they are that something bad is happening. So I certainly see normal results as no issue. I think abnormal results, there is a danger there of actually exacerbating anxiety, and Dr. Google is bad enough currently, and always seems to say something terrible is going to happen to you. And I think if people start getting abnormal results without having a clinical understanding of what it means, they're going to go to Dr. Google, and it's going to cause a lot of anxiety. So yeah, it's a bit of a minefield, and I think we have to think through the implications pretty carefully.
Thank you. And I've got another question here from the audience. Was there a trigger to conduct the study in the first place?
That's a good question. It's a long time ago. I don't know that we necessarily had a specific incident that triggered the initial study. I think that we certainly had instances where it became apparent that a result had not been acknowledged and had led to some sort of problem, but I don't remember any particular standout, critical incident. But I think it was just a lot of lesser incidents which caused, some degree of discomfort or confusion or, inconvenience to patients. And, we all go to work and we want to do our best for patients. That's our driver. And to see that we did a fabulous job when they were with us, and then we dropped the ball when they went home, I think was what kind of, stuck in our heads and made us think, actually, we need to be doing this better. But I don't think there was a particular one case that I remember.
Okay, thanks, Richard. So we're probably coming to the end of our time. I have one last question for you. So you mentioned in your presentation the issue of low value care.
Mm-hmm.
And I was just wondering your thoughts on the challenges that we have currently in the system to identifying and mitigating low value care, mm-hmm. and what you think is needed to help overcome these barriers.
Yeah, again, it's a huge question, and could be a whole other talk. I think that we need to take care not to go down the defensive medicine route. If we look to the US in particular, where litigation is very high, and defensive medicine has become the norm, and so you do a whole lot of tests, which really don't add value to the patient care and potentially actually make things worse. Every test carries some possibility of a false positive or a false negative result, which then results in doing more tests, which then results in more false positives and negatives. And there are lots of examples of where somebody has been sent for an initial test that they probably didn't need, and then that has led to another thing and another thing and another thing and a bad outcome. So I think, we have a responsibility to find that balance between too many tests and too few tests. And I think that comes back to what I talked about in the first slide, going back to first principles, that we make a clinical assessment, we come up with a provisional and differential diagnosis, and then we actively think about what tests are going to help me better discern which of these things is affecting this patient in front of me. And I think, so I think a lot of it is about mental discipline. And I think a lot of it is about training, because it's very easy to get into the mindset that you just order tests because somebody's going to say, well, you should have ordered a test. And it's always easier to do things than not to do things. And you rarely get criticized for doing things. You're much more likely to get criticized for not doing things. And so I think there's a whole culture and a whole mindset, and there's also, societal and patient expectations in there as well, about, when you don't order something and then subsequently there is an issue, it's very, very hard to, necessarily reconcile that with patients. But I think we've got to try and find that balance and not get overly defensive.
I agree. Thank you very much for your time today, Richard. That was a very interesting presentation and conversation. We really appreciate it. So if you are interested to know more about value-based healthcare and the Australian Centre for Value-Based Healthcare, we host regular webinars on topics related to value-based healthcare, and that can include low-value care, clinical registries, all those different types of things. In June, ALHA is also hosting value-based healthcare pioneer Elizabeth Teesberg and her colleagues from the Value Institute of Health and Care at the University of Texas to work with health professionals from across Australia and the health system to improve the depth of understanding, both in theory and practice, around what it means to measure what matters in the Australian context. The workshop will also include a roundtable discussion on measuring what matters in Australia, with the intent of identifying how this integrates with existing systems and where we need to do things differently. More information on this, if you're interested, can be found on both the ALHA and the Australian Centre for Value-Based Healthcare website. We also have a newsletter. If you're interested, you can subscribe, and we have a number of different regular newsletters based on what you're interested, including an Australian Centre for Value-Based Healthcare one. So you can also subscribe to those both on our website. Once again, I want to thank you all for joining us today, and thank you, Richard, for your time. And we hope to see you again at one of our upcoming events.